Christina, Kia, Jackie, and myself, Annie, will be discussing hypertension in this video. We will be going through an introduction, the pathophysiology, diagnostic testing, medications, nursing diagnoses, patient education, discharge planning, ethical dilemmas, and a research article during this video. We also have included a patient scenario for the viewers to see. So what is hypertension? Hypertension is a condition in which the force of the blood against the artery walls is too high, causing abnormally high blood pressures. Hypertension is a very common condition. 33% of the adult population in the United States is living with hypertension. About 46% of the adult population does not have their hypertension under control. Hypertension is the most common chronic disease among U.S. adults. Another name for hypertension is the silent killer, because most patients are often symptom-free. Hypertension varies in ethnicity and gender. African Americans are among the highest ethnicity in the world that develops hypertension, and usually at younger ages. 46% of African American men and 45% of African American women are affected with hypertension. Other statistics show that 33% of Caucasian men and 30% of Caucasian women are affected with hypertension, while 30% of Hispanic men and 30% of Hispanic women are also affected with hypertension. Risk factors for hypertension include dyslipidemia and/or the abnormally elevated cholesterol or fats in the blood, diabetes mellitus, which is a metabolic disorder in which there are high blood sugar levels over a prolonged period of time, sedentary lifestyle, which is a lifestyle that contains little to no physical activity, family history of a cardiovascular event such as a stroke or heart attack, metabolic syndrome, which is a cluster of conditions such as high blood sugar or high blood pressure that increases the risk for heart disease, stroke, and diabetes, cardiovascular conditions such as heart failure, coronary artery disease, or stroke, obstructive sleep apnea, which is an intermittent airflow blockage during sleep, or smoking. Although smoking does not cause hypertension, it does increase the risk of dying from cardiovascular disease for patients who have hypertension. A key factor in understanding hypertension is first understanding blood pressure. Blood pressure is the force of blood pushing against blood vessel walls. It is written in two separate numbers and is measured in millimeters of mercury, or mmHg. The top number is the systolic blood pressure, which indicates how much pressure your blood is exerting against your artery walls when the heart beats. The bottom number is your diastolic blood pressure, which indicates how much pressure your blood is exerting against your artery walls while the heart is resting between beats. There are 4 stages of hypertension. A normal blood pressure is less than 120 and less than 80. A patient may be diagnosed with prehypertension if your systolic blood pressure is between 120 and 139, or if their diastolic blood pressure is between 80 and 89. During this stage, it is very important for patients to make lifestyle changes and to seek help to get their blood pressure under control. If they do not, they are likely to develop a worsening stage of hypertension. After prehypertension comes stage 1 hypertension. If a patient's systolic blood pressure is between 140 and 159, or if their diastolic blood pressure is between 90 and 99, doctors are likely to prescribe blood pressure medication, which we will discuss later in the video, but only if the patients have already experienced a cardiovascular disease, such as stroke or heart attack. Doctors will definitely recommend lifestyle changes. Medical attention is sought out in a hypertensive crisis. This is where the blood pressure readings suddenly exceeds 180 over 120, which can possibly cause organ damage. If you would like more information regarding the understanding of blood pressure readings, please visit the American Heart Association at www.heart.org. Hypertension occurs as primary hypertension or secondary hypertension. 95% of patients are affected with primary hypertension, which has an unidentifiable cause. 5% of patients are affected with secondary hypertension, which has an identifiable cause. The causes of secondary hypertension include chronic kidney disease, renal artery stenosis, mineralocorticoid hypertension, phenochromocystoma, sleep apnea, or pregnancy-related. Next, we will be discussing the pathophysiology of hypertension. Each time the heart contracts, Pressure is transferred from the contraction of the heart muscle to the blood, and then pressure exerted by the blood as it flows through the blood vessels. Hypertension can result from increases in cardiac output, increases in peripheral resistance, which is the constriction of the blood vessels, or both. Increases in cardiac output are often related to an expansion in vascular volume. No precise cause can be identified for most cases of hypertension. For hypertension to occur, there must be a change in one or more factors affecting peripheral resistance or cardiac output. In addition, there must also be a problem with the body's control systems that monitor or regulate pressure. The tendency to develop hypertension is inherited. However, genetic profiles alone cannot predict who will and who will not develop hypertension. As stated previously, there are no precise causes of hypertension. We included possible causes of hypertension. These include increased sympathetic nervous system activity related to dysfunction of the autonomic nervous system, increased renal reabsorption of sodium chloride in water related to a genetic variation in pathways by which kidneys handle water, increased activity of renin-angiotensin aldosterone system resulting in expansion of extracellular fluid volume and increased systemic vascular resistance, decreased vasodilation of the arterioles related to dysfunction of the vascular endothelium, resistance to insulin action, which may be a common glycemia, obesity, and glucose intolerance, activation of the innate adaptive components of immune response that may contribute to renal inflammation and dysfunction. As you age, structural and functional changes in the heart, blood vessels, and kidneys contribute to increases in blood pressure. Those age-related changes include accumulation of atherosclerotic plaque, fragmentation of arterial elastins, increased collagen deposits, impaired vasodilation, and renal dysfunction. The result of these changes is decreased elasticity or stiffening of the major blood vessels, particularly the aorta, and volume expansion. The aorta and large arteries are less able to accommodate the volume of blood pumped out by the heart, and the energy that would have stretched the vessels instead elevates the systolic blood pressure, resulting in an elevated systolic pressure without a change in diastolic pressure. Now, Christina will be discussing diagnostic tests.
Some diagnostic tests for hypertension and some assessments is the doctor will always start by obtaining a general health history of the patient. This includes any lifestyle choices, the lung sounds, the heart sounds, and other general vitals. They'll also ask family history, their eating habits, and whether they have a sedentary lifestyle or they're active. But the one true test that diagnoses hypertension is a blood pressure reading. As stated in an earlier slide, anything over 120/80 can be problematic. The doctor will perform 2 to 3 readings on each arm throughout a few visits before they truly diagnose the patient as hypertensive. This is because they want to compare each arm, and they also want to make sure they rule out white coat syndrome, which is when a patient has an elevated blood pressure just because they're nervous at the doctor's. Once those are ruled out, the patient officially is diagnosed with the disease. Through the initial part of the diagnosis, they may ask the patient to wear an ambulatory blood pressure cuff, which takes the blood pressure at regular intervals through a 24-hour period. This gives the doctors a clear picture of your blood pressure and how it fluctuates throughout the day. The doctor might also order several tests, mostly to ensure that hypertension has not reached the major organs, causing organ damage. A urinalysis may be ordered to assess kidney function. A blood test may be ordered to check the sodium, potassium, creatinine, and fasting glucose. They also may want to order a cholesterol test to assess both the total and the HDL cholesterol levels. The last test that is common is a 12-lead electrocardiogram. This evaluates your heart rhythm and how effectively the blood is pumping. Now moving on to medications for hypertension. There are several kinds of drugs to help control hypertension. We're going to focus on the categories of diuretics, adrenergic inhibitors, angiotensin inhibitors, and calcium channel blockers. Diuretics, which are more specifically thiazides, loops, and potassium sparing, produce increased urine flow by inhibiting the kidney's ability to reabsorb sodium and water. This reduces preload and decreases afterload, allowing for the heart to pump more efficiently. However, with all diuretics minus the potassium sparing, we must advise the patient to eat foods rich in potassium to avoid hyperkalemia. Beta adrenergic blockers block beta adrenergic receptors in either the heart and kidneys, which is beta 1, or other parts of the body, such as the lungs, which would be beta 2. This means that this drug may not be good for patients presenting bradycardia or for asthma patients. You must also educate the patient not to stop these drugs abruptly because it could cause rebound hypertension or exacerbate ischemic heart disease. Angiotensin inhibitors, more specifically ACE inhibitors, block the enzyme needed to form a substance that narrows blood vessels. This causes blood vessels to relax and widen, making it easier for the blood to flow through the vessels. For these drugs, you must be wary in taking NSAIDs because they could contradict the medication and also can cause renal failure. Also, be aware for minor side effects such as rash, cough, loss of taste, and angioedema. The final category of drugs we will discuss are calcium channel blockers. These drugs block the calcium access to the cells. This lowers contractibility and conductivity of the heart and lowers the demand for oxygen. Monitor the dioxin levels in the patient because this drug can lead to dioxin toxicity. Check for side effects including bradycardia, abdominal distension, and peripheral edema. Initially, instead of jumping directly to a pharmacological treatment, the doctor will first recommend that the patient modifies their lifestyle. This includes losing weight, exercising more, and taking less alcohol, and decreasing the salt in their diet. If after the month there is still no improvement, the doctor will prescribe you an antihypertension drug, depending on factors such as age and race, but we'll go into that later. If you're still not at a goal, the doctor will continue to push the importance of lifestyle modifications. He'll also maximize the dose of the current medication you're on, plus add another. If you end up still not at goal, he will continue to educate about reinforcing a healthy lifestyle. They will maximize your current drugs and they'll even add more. Finally, if you're still not at goal, they will plead that you take on a healthier lifestyle. They'll add any drugs that they have not tried, and they'll refer you to a hypertensive specialist. If at any time your blood pressure does stabilize for at least a year, the doctor will start weaning you off of medications. This is because less is more, and the overall goal is to control the blood pressure with minimal side effects, so the less drugs, the less side effects. As I mentioned earlier, your initial medication does depend on factors such as age and race. In the next few slides, we will introduce different patients with stage 1 hypertension and see how differently their medications are treated. We will start with a non-African American patient who is less than 60 and has been diagnosed with stage 1 hypertension. This patient is started on either an ACE inhibitor or an angiotensin II receptor blocker. If after a few months this patient shows no progression, they will add a calcium channel blocker or a thiazide diuretic. If the patient still shows no progression in a few months, the patient will then add a calcium channel blocker or a thiazide diuretic, whichever they did not add previously. If this patient still cannot get a hold of his blood pressure, the doctor will try to add other drug combinations and titrates, such as spironolactone, beta blockers, or central acting agents. Finally, if all other medications have failed the patient, he's referred to a hypertensive specialist for further examination. We will now look at a non-African American patient who is 60 or older who has been diagnosed with stage 1 hypertension. This patient is started on either a calcium channel blocker or a thiazide diuretic. If after a few months the patient shows no progression, they will add an ACE inhibitor or an angiotensin II receptor blocker. If this patient still shows no progression after a few months, the patient will add a calcium channel blocker or a thiazide diuretic, whichever one they were not originally prescribed. If this patient still cannot get a hold of his blood pressure, the doctor will try other drugs such as spironolactone, beta blockers, or central acting agents. Finally, if all medications have failed this patient, he is referred to a hypertensive specialist for further examination. Finally, we'll review an African American patient who has been diagnosed with stage 1 hypertension. For African American patients, age does not play a factor. This patient is started on either a calcium channel blocker or a thiazide diuretic. If after a few months this patient shows no progression, they either do a combination of a calcium channel blocker and a thiazide diuretic, or they add an ACE inhibitor or an angiotensin II receptor blocker. If this patient still shows no progression in a few months, the patient will then add a calcium channel blocker or a thiazide diuretic, whichever they did not add previously, and an ACE or the ARB. If this patient still cannot get a hold of his blood pressure, the doctor will try to add other drug combinations and titrates such as spironolactone, beta blockers, or central acting agents. Finally, if all medications have failed this patient, he is referred to a hypertensive specialist for further examination.
Nursing diagnosis. Examples of nursing diagnosis for hypertensive patients includes number 1, decreased cardiac output related to increased perivascular resistance as evidenced by a blood pressure of 150/90. This refers to inadequate pumping of the blood to meet the metabolic demands of the body. With these patients, the nurse's focus is to maintain the blood pressure below at least 140/90 or less than 150/90 in older adults by the use of thiazide diuretics. Number 2, ineffective health management related to complex treatment regimen as evidenced by non-adherence to follow-ups and medication consumption. So the nurse's top priority will be to find ways to decrease the amount of and or the frequency of the pills taken and evaluate the reason for the patient not following up. Number 3, deficient knowledge related to therapeutic effects of medication regimen as evidenced by the patient expressing, I do not understand why I need to take all these medications. With this diagnosis, the patient is unable to keep up with everything that needs to be done to treat the disease. Proper education on the pathology of the disease and the long-term effects on the body, as well as proper teaching about the importance of the treatment regimen, increases the patient's knowledge, which may result in a better compliance rate. Lastly, imbalanced nutrition, more than the body requirements related to high caloric intake, as evidenced by BMI 30.2. An overconsumption of sodium in a diet may contribute to increased blood pressure. American Heart Association recommends a daily intake of 2,300 milligrams per day for healthy people, and for hypertensive patients, 1,500 milligrams per day. So the nurse's plan of care will be to introduce dietary modifications. Patient education. Of course, as nurses, we always want to educate our patients. For the patients with hypertension, you would want to explain the disease process. That is, describe what hypertension is and how it affects the body. You want to talk about treatment regimen that would emphasize in the therapeutic and adverse effects of the medication, the importance of self-involvement, that is taking your blood pressure on your own daily, and the importance of follow-up. Nurses want to introduce the dietary approach to stop hypertension, that is the DASH diet, to encourage a reduction of sodium but an increase in nutritional rich food which contain potassium, calcium, and magnesium to help lower blood pressure. And lastly, you want to encourage an active lifestyle, promoting exercise daily.
Next is discharge planning. Discharging is a process used to decide what a patient needs for a smooth move from one level of care to another. Only a doctor can authorize a patient's release from the hospital, but the actual process of discharge planning can be completed by a social worker, nurse, or case manager. Discharge planning is done with a team approach. Effective discharge planning can decrease the chances of the patient being readmitted to the hospital and can also help in recovery. We must ensure medications are prescribed and given correctly. They make a change in their lifestyle, which is daily routines, follow up with their healthcare provider, and know when to seek medical attention. What they should be doing is taking their medications regularly, take your blood pressure medicine exactly as your doctor directed, learn the side effects of any prescribed medications, tell your doctor about any medications you do take right now, avoid medicines that contain heart stimulants, including over-the-counter drugs, and check for warning about high blood pressure. Check with your doctor before taking a decongestant, because some can worsen the high blood pressure. As far as the lifestyle changes, top main thing that patients should do is cut back on their salt intake. Don't add salt onto your food on the table. Request foods at restaurant without salt. Begin an exercise program. Ask your doctor how to get started. You can benefit from simple activities like just walking or swimming or dancing. And to not drink alcohol. That's one of the main things as well. Control your stress. Stress plays a big part in hypertension. Healthier choices all around, and eliminate smoking if possible. The American Heart Association ideal sodium intake recommends 1,500 milligrams per day. However, since Americans eat so much salt, the American Heart Association says a positive change can occur by cutting back to even 2,400 milligrams of sodium per day. As stated earlier in patient education, patients should follow the DASH diet, which is Dietary Approaches to Stop Hypertension eating plan. This plan recommends vegetables, fruits, whole grains, and other healthy foods. And one of the other discharge approaches should be follow-up care. Make a follow-up appointment with your doctor regularly and visit your doctor for blood pressure checks, dietary advice, and medicine adjustments. When to seek medical attention. So if you're having chest pains or any weakness or trouble speaking, confusion, or a blood pressure measure at home that is greater than 180 over 110, that should be addressed as well. And a good support system. It is important to have a family and friends by your side for support. Support helps for having many positive benefits, such as higher levels of well-being, better coping skills, and a longer and healthy life.
Now Christina will discuss ethical dilemmas.
When we're treating a patient, it is easy to just give them a plan that we think will work for them without actually asking them what they want. The patient is not part of the decision-making process a lot of the time. Usually, we just expect them to comply and don't understand when they don't, or we get angry with them on what they've done. We must respect that some of these patients will not 100% comply with their regimes, and we cannot get mad at them for it. The individual's perspective and goals certainly affect their adherence with the medical treatment, and they can't be ignored. If something's not working for them, instead of giving up on them, we must go back and edit it. We also need to ensure that we're always there and always 100% honest with the patient. An ethical dilemma that arises and breaks both truthfulness and beneficence is when we're prescribing the patient a drug and the side effects can do more harm than good. It also is hard to be truthful about all the possible side effects because you want them to adhere to your plan. However, we must make sure we're giving the patient all the education they need so they can make their own educated decision with all the facts.
Next is the research article discussion, and the scholarly research article I found was very interesting and full of so much information from their study in the Midwest region of Nepal regarding hypertension. The study revealed high prevalence with low awareness, treatment, and control of hypertension in the country. Gender, age, ethnicity, smoking, drinking alcohol, and body mass index were associated with hypertension. Immediate public health and individual measures are warranted to reduce future burden of cardiovascular disease. So in this article, I found 3 really incredible tables that broke down hypertension and all the different factors that play a role in it. So table 1 had demographics of socioeconomic, behavioral, and characteristics of study by each subject of sex, so female and male. The next table had factors associated with hypertension, so people who have hypertension right now. And table 3 had behavioral factors associated with hypertension. So the current study revealed about 2/5 of the participants had hypertension in the suburban district of the Midwest region of Nepal. So age, sex, ethnicity, smoking status, use of alcohol, and BMI were significantly associated with this disease. Despite the high burden of hypertension, only half of them were aware of their condition, only 1/3 were received the treatment, and 1/10 had controlled blood pressure. So, as medical professionals, we should advocate to these patients and provide the best practice and care for them. Engage staff, physicians, patients in proper blood pressure technique, create a 2-week follow-up process, and adopt and promote hypertension protocols. In this article, you can see all the factors that play a role in hypertension and the do's and don'ts. One thing this article states is how you can receive help from not only the nurses, but community organizations as well. So community organizations can help with services such as transportation, meals, support groups, counseling, possibly a break from your care responsibilities to allow you to rest and take care of yourselves. Finding those services can take some time and several phone calls. The discharge planner should be familiar with these community supports, but if not, your local senior center or private case manager might be helpful. Family and friends also might assist you in this home care. So this article really broke it down as far as hypertension, what it is, what plays a role in it, the treatments, the benefits of it, and all that tied in together into this article really broke it down.
Now we will be doing a hypertension patient scenario. First, we will start with an initial visit.
Come in.
Hi, Kia.
Hello.
How are you today?
Good, how are you?
Good. My name is Annie. I'm going to be your nurse, okay?
Okay.
So I just closed the door so you know that everything that's in this room is private. Do you feel safe right now?
Yes.
Okay, perfect. I just want to come and recheck your blood pressure because it looked a little elevated. This could be because of a white coat syndrome, which means like you haven't been to the doctor's in a while, you might be nervous. Yeah, so I'm just going to recheck that. Can I just see your name tag?
Sure.
Can you tell me your name and date of birth?
Shaquille Willis, May 30, 1995.
Perfect. Okay, so can you just rest your hand up for me?
Sure.
Okay, so it still seems to be elevated. It was 142 over 90. I will have the provider come and talk to you, but first he wanted to get a little family history, okay? So do you mind if I ask you a few questions?
No.
Okay. Okay. So first question, can you just tell me about your like daily life? Like, do you have any stressors? Like, what do you do for work?
I have about my husband, 3 children. I work like 9 to 5 at the doctor's office as a secretary.
Monday through Friday?
Monday through Friday, and everything happens really quick at home. You know, I have to make easy meals, and so the children can have. I don't have much time for myself, and when I'm like not working, I'm not up to do anything but like relax and get some rest. So that's about it.
Yeah. So it's good that you talked about the meals. That was going to be my next question. What's like your typical breakfast, lunch, and dinner? Like, do you cook yourself? Do you go out to eat a lot?
Yes. Me and my family, we love to go out to eat just because like neither of us have much time to cook food. So like yesterday I had like a cereal and orange juice for breakfast. Then I was at work, so at lunch I ordered some Chinese food. And for dinner, when we came home, we had some pasta and meatballs and some juice.
Okay. So does it look like you have like a lot of sodium in your diet?
I'm not sure. I never like look at.
Okay.
sodium.
Do you use a lot of salt when you cook, or like if you go out to eat, do you put salt on your?
Yeah.
Yeah.
Salt on everything.
Okay. Okay. So do you have any family history of like any diseases, like maybe hypertension or high cholesterol?
Yeah. My dad has hypertension, and also my maternal grandmother had hypertension, and she had high cholesterol, and she had diabetes.
Oh,
she had
wow.
a lot. Yeah.
Did she take medication for high cholesterol?
She had to take a lot of medication.
And you said your dad had hypertension as well.
Yes.
Did he take medication?
Yes.
Okay. All right. Do you drink alcohol?
Yeah, I do.
Like socially, or like would you say like once a week, maybe on the weekends?
Maybe like 3 times a week.
3 times a week?
Yeah.
Okay.
Well,
Okay.
I like to sip wine and watch TV.
Okay. And do you exercise at all? Any?
Yeah, I happen to have a gym membership that I've never used.
Oh.
Yeah.
Oh wow.
Yeah, not much. Like, I think running around with the 3 children is enough exercise.
Enough.
Yes.
Okay. All right. Well, you answered all the questions that I needed to get. I'm just gonna go call the provider, and then we're gonna come in together to see you again. Okay?
Okay.
Okay.
Hi, Tia. I'm Dr. J. I'm just going to come in here and talk to you for a moment. I'll sit down. Okay, so based off your current blood pressure readings, it is elevated. Now, we're not going to panic to start. I mean, it's your first time at the doctor in a while. My nurse is going to explain to you exactly what I want you to do. We're not going to start any meds yet. She'll go into that with you. But I do want to see you back in about 3 months because your ethnic background, your family background puts you at a pretty high risk, your lifestyle. So we definitely want to get a hold of this now before it turns into something. Okay? I'm going to have my nurse Annie that you spoke with earlier. She's going to give you your instructions. I informed her, and we're going to get you taken care of, okay?
Thank you so much,
See you
Doc.
soon.
Okay, so I printed out some sheets for you for
Okay.
education purposes. So the first sheet, this is all about diet modification. So you told me that you have a lot of salt in your diet right now, so we're gonna cut that out, unfortunately. We're gonna have to try new seasonings, maybe try to go to the grocery store. There's a lot of seasonings that don't have salt added to them, and also try to incorporate, like you said you had cereal for breakfast before. Maybe try a whole grain cereal, add some fruits and vegetables in there. Try to eat out less. I know that's gonna be a hard part, but try going to the grocery store and getting like vegetables, natural chicken, stuff like that. So it's like healthier because it's really gonna affect your blood pressure. It's beneficial. This is another sheet. It's about exercising. So you told me you have a gym membership that you don't use a lot. Try using it at least 3 times a week, even if it's like walking on the treadmill for 30 minutes. Or I know like you have children and it's hard to add that exercise in. But also like if you don't feel like you have time to use that gym membership, take your kids around the block, or like just try to like move more and like exercise at least 3 times a week. Okay? This third sheet is all instructions for your next visit. You're going to come back in 3 months. We're going to recheck that blood pressure. Hopefully you have your lifestyle modifications under control and everything will look better. Okay? So if you have any questions, please call either myself or your doctor. We put the 2 numbers down here.
Okay.
It was nice meeting you.
Nice to meet you.
Now we will check back with the patient for a 3-month checkup.
Hello.
Hi, Tia.
Hello.
Dr. G again. How you feeling now? Lately, good?
I'm okay.
Okay. So, your blood pressure was still pretty elevated. At this point, I think we're gonna go with the diagnosis of stage 1 hypertension. But it is something that we could reverse and bring back down. Have you changed your lifestyle? Have you followed your nurses? Cut sodium at least a little, exercise a little.
I mean, I tried, but the no salt seasonings, they're a little expensive, and it's hard to not eat out because I don't have time to cook, and it's easier to grab the children and go. Yeah.
Okay. Well, I really still want to push that. Maybe try meal prepping Sundays before your 5-day work, at least for you. Maybe cook a little. Ask the husband, maybe he'll cook for the kids at night so you could go after work, get a little exercise in. Just really want to push that lifestyle. Also, we're going to add a medication. I wrote it down for you. I sent it to your pharmacy. So the medication we're going to start you on is going to start with a calcium channel blocker. This one's called, it's a dihydropyridine. This one's called nifedipine. It's going to lower your heart. Your heart's not going to have to work as hard to pump, so it's going to let it pump more efficiently. Okay, so here's that.
Thank you.
So, like I said, I really do want to push that lifestyle, though, because we definitely want to modify the things that are modifiable. Your ethnic background, your family history, we can't change that, but we can change your diet, your sedentary lifestyle, and we could try to get that down, because less is more in medication. Next time we might need to add more, and we don't want to keep adding medications. Even more crazy in your busy lifestyle. Okay, so we're going to give you that. Going to have to see you back in another 3 months to recheck it.
Okay.
In the meantime, you say you work at a doctor's office. I want you to maybe check your blood pressure so you know for yourself, maybe 2 to 3 times a week, just so you know. Maybe you're more conscious of it, because I know right away it's easy to feel it. Like right now, you want to go change it, but maybe in a few weeks you fall off. At least keep your constant reminder.
Okay.
You want to be around for your kids.
Yes.
So we're gonna make sure we get that back down for you.
Okay.
All right. Any questions?
Yeah, I was just saying, I've never had any symptoms of anything, I've never been sick. The last time I was in the hospital was when I was born.
Yeah. Hypertension is the silent killer. Not scary, but usually not symptoms. When you do get symptoms, it tends to be in the later stages. It could affect your kidneys, it could affect your eyes. We don't want to get there. We are going to run some blood work. I'll send you to Quest. We'll check your creatinine levels, make sure there's no renal damage. I mean, you are at stage 1, so we shouldn't get there, but we definitely want to get in order so those things don't happen. But you're not going to feel any symptoms till it's too late. So let's get this in control together. We're definitely going to take it from here and fly with it.
Okay. Thank you, Doc.
All right.
Have a good one.
See you in a few months.
All right.
We hope you enjoyed our presentation on hypertension. Here are a list of references we use throughout our presentation on hypertension.